Hey everybody, my name's Matt. I'm a respiratory therapist. I've been doing it for about 5 years, and I've been asked to do education for respiratory students, nurses, residents, nursing students. So I figured I might as well just record a video while there's a pandemic going on. So the first one I'm going to do is arterial blood gases, or ABGs, and let's get started. So we do need to get a little bit of blood. No, I can't draw from an IV. It may hurt, may not. Depends on how you do with the whole thing. So why do we do ABGs? We just want to check on a patient's respiratory status on the ventilator. We also want to check the hemodynamically unstable patient's inotropic support level. So if you had a patient who's on like dopamine or dobutamine, digoxin, or another inotrope, it's always good to see how well you're doing after you start them on that drip. Also, we do them fairly often for metabolically unstable patients like DKAs. And sometimes you just need to check the overall acid-base balance, like with your patients who have COPD and they're possibly having an exacerbation. So just some basic stuff. We have conducting versus respiratory airways. Conducting airways, there's no respiration, no gas exchange. It's just what we call anatomical dead space. Now, the actual respiratory airways are the bronchioles, alveolar ducts, alveolar sacs, and alveoli, where there is actual gas exchange going on. This also, dead space also includes your vent circuit, the ET tube, and other forms of dead space, and we call that mechanical dead space. And then we also have physiological dead space versus anatomical, and the physiological is just all the space not involved in, including unventilated alveoli, which we do happen, from time to time. So if you have like a mucus plug or something that is causing alveoli to not get ventilated, pneumothorax, pleural effusions are very common, especially for someone like me who works in a trauma center. Pneumonias happen all the time. I work here in Florida with an older population, so everybody's got COPD and everybody gets pneumonia this time of the year. So gas is diffused from a higher concentration to a lower concentration. O2 moves into the red blood cells, and CO2, moves into the lungs to be exhaled out. That O2 is then transported to various parts of the body, and then CO2 picked up, taken back to the lungs, and exhaled out. It's pretty easy. We do it till we die. So more basic knowledge. That's Spanish, by the way. Oxygen is transported by hemoglobin in 97% of the blood. Hemoglobin transports 97% of the oxygen in the blood. O2 is dissolved into the plasma. It only accounts for about 3%. And it goes in there by diffusion, just like how every other gas moves. And then the hemoglobin then dumps that into the plasma. And then we just keep doing that until the SaO2 is depleted, and it results in a depletion of the driving pressure of the plasma available, and then that's how it goes for the carbon dioxide. This is French, by the way. We have the Oxyhemoglobin Disassociation curve. It's just a small graph, an S-shaped graph that just looks and shows you, the relationship between your hemoglobin saturation, or in this case the SaO2, versus dissolved oxygen. And there's things that will increase the affinity for oxygen to hemoglobin, which is a temperature lower than 37, a higher pH, alkalosis. And then we have things that'll decrease the affinity, which means that's going to offload the oxygen into the hemoglobin better, which is a temperature higher than 37 and then a decreased pH. So notice how if you run a fever or you have a respiratory acidosis, that your oxygen is offloaded easier to help with the healing process, or to compensate for what your body isn't giving you because of its current situation. So that's German, by the way. We have certain abnormalities of hemoglobin that can throw your numbers off, like increased carboxyhemoglobin due to carbon monoxide poisoning, the Haldane effect, Methemoglobin can be an issue for patients who are on nitric oxide for too long. And then sometimes due to increased nitrates or Pepto-Bismol toxicity, the iron in your hemoglobin can actually oxidize from a ferrous to a ferric state. And these patients actually have blood that turns like a brown color. And then increased methemoglobin does not carry oxygen at all. And that's what it looks like. And you can see if you look at where the arrow is at the decreased pH number. So if it looks to be about 45. So when your pH goes down and your oxygen saturation is decreased, so that arrow is roughly, if you're set in 65%, your PaO2 is about 42. Whereas if you're setting normally, or your pH is normal, everything's normal, if you're setting 80%, you're at about 42. So it can definitely throw things off a little bit. And usually, in respiratory, we have a saying that a PaO2 of 60, 70, or 80 is a SpO2 of 70, or I'm sorry, 80, 90, and 100%. Or I'm sorry, PaO2 of 60, 70, or 80 is an SaO2 of 80, 90, and 100. So a PaO2 of 60 is at a saturation of 90% if your pH and temperature are normal. So just a few numbers to know. These are your normal pH values. And for the nursing students, if you want to do the Rome method, the tic-tac-toe, that's up to you. But when I was in respiratory school, just know the numbers, know the ranges, and it'll actually fare you a lot better. And the best practice you're going to get is by looking at 1 million ABGs. And you're going to have to deal with them. We're all going to have to deal with them, unfortunately. And it is what it is. And so it's easier just to know your numbers and know your ranges. And I'll have a couple of charts up, and we'll figure out what we can do here. So just 5 questions you want to ask yourself when you look at an arterial blood gas. Look at the PaO2 first. Is the patient hypoxemic? Low oxygen will kill you faster than high CO2. Little fun fact for you. So is the pH alkalotic or acidotic? Is the PaCO2 alkalosis, acidosis, or normal? Same thing with the sodium bicarb. So look at the pH again when you have all your other numbers, and is it compensated or not? And we don't allow Smurfs. No one has a blue color where I come from. So your PaO2, it's the partial pressure of oxygen dissolved in the arterial blood plasma. We measure it in millimeters of mercury, or torr, depending on where you live. And it only represents, 3% of the total oxygen in the blood. So in room air, at 21%, your normal PaO2 should be roughly 80 to 100. And there's certain things that are going to affect it. Your age, altitude. I live in Florida. It's going to be different for someone who lives in, let's say, Denver. Your overall VQ matching, if you have a shunt or something like that, that is causing the blood not to return back to the alveoli to get reoxygenated. Pulmonary embolism is very common. And just the overall driving pressure, your FiO2. I really hope that if you're on 100% oxygen, your PaO2 is above 80 to 100. And then I always look at the PaO2 first. It may signify, the patient requires immediate escalation of medical care, like intubation if your numbers are less than 40. Some literature will tell you 45, but you always have to judge it by looking at the patient and just seeing where they're going. If you're trending down to 40, you might want to intubate sooner than later. pH. It's the hydrogen ion concentration in the blood plasma. It's calculated using PaCO2 and sodium bicarb. It's calculated using the Henderson-Hasselbalch equation, 7.35 to 7.45. Less than that is an acidosis. Greater than that is an alkalosis. And there's the equation. I use it every day when I'm practicing, especially when I'm rounding with the physician. He has to wait for me to do the math. No, I'm just kidding. We don't do this at all. But the PaCO2, it's the partial pressure of carbon dioxide dissolved in arterial blood plasma. Same thing with PaO2. That's what the P stands for, is partial arterial carbon dioxide. So that's also measured in millimeters of mercury, 35 to 45, and we check this number to see the body's ability to adequately ventilate, and we check the ventilatory status of a patient on the ventilator if we have to, or a BiPAP. We do this very often with our COPD exacerbations while they're on BiPAP to see if we need to escalate care or give them a break off the mask, and hopefully maybe they can get some breakfast or something. So respiratory acidosis, it's also called alveolar hypoventilation. This is most commonly seen with patients who have COPD, patients that are over-sedated, head traumas, anesthesia fresh out of the OR, your neuromuscular disease patients, your myasthenia gravis, your Guillain-Barrés, or inadequate mechanical ventilation. Better call respiratory. And then, less than 35 is a respiratory alkalosis or alveolar hyperventilation. It can be caused by hypoxemia. The sensors in your heart are causing you to breathe faster to bring more oxygen in the blood, but in the meantime, you're also going to ventilate more. Anxiety can be a big one, a PE, pregnancy, and then hyperventilation with a mechanical ventilator, just to name a few. Acute ventilatory failure. These patients have a PaCO2 above 50 millimeters of mercury. Their pH is less than 7.3. The pH is abnormal, and the body just has not had time to return it to a normal range by secreting increased levels of sodium bicarb. That's where the alveolar hypoventilation comes in. These are patients that are, fresh out of the OR or something like that. They're over-sedated, your drug overdoses. Pick whatever you want to throw in there, and then you have this is your average COPD, or a PaCO2 above 50. Their pH is relatively normal, 7.34, 7.35, but above 7.3 is in their norm. And then the pH is being buffered by increased levels of sodium bicarb. The kidneys are compensating for that acidosis created by carbon dioxide. And then your sodium bicarb, your kidneys produce it, or we give it artificially with medication, and it buffers the acidity of carbon dioxide. Your normal range is 22 to 26 MEQs. Some books will say 28. I was always taught 26, but two MEQs isn't going to really make a difference one way or another. But anything less than 22 is a metabolic acidosis. These are your DKAs, your lactic acidosis, your renal failure patients, and then patients that have had chronic diarrhea, usually around 7 days or more. We have a saying, you lose your bases out of your butt and your acids out of your gut, so just keep that in mind. An increased sodium bicarb is greater than 26. This is an alkalosis. These are patients that have been chronically vomiting. Patients who have NG output, patients on diuretics, severe hypokalemia, or you give, alkali administration. Like I said, you give them a syringe full of sodium bicarb, or patients on long-term, or not necessarily long-term, but patients who are taking steroids. And patients will also have an increased alkalosis commonly after getting a shot of Lasix too, and that's where the diuretics come in. So compensated versus uncompensated, this is very difficult for some people to understand. So if you need to pause the slide and read it a few times, I highly encourage it. So if the patient's uncompensated or if they're compensated, you always want to look at partial, fully, or not at all. So if the pH is abnormal, the PaCO2 and the bicarb are abnormal, and the resulting alkalosis or acidosis, it's uncompensated. Now I have more pictures here in the next couple of slides that'll show you what partial compensation looks like. But if the pH is normal and the PaCO2 and the bicarb are abnormal, the resulting alkalosis or acidosis is compensated. So we'll see what that looks like. So you have a respiratory acidosis. Your pH is less than 7.35. Your PaCO2 is greater than 45. But your bicarb's still in the normal range. That's an uncompensated respiratory acidosis. Your pH is still off, the PaCO2 is up, hence respiratory acidosis, and your bicarb's increased, but the pH is not at 7.35. That's a partial compensation. Now, if your pH is 7.35 to 7.39, and your CO2 is above 45, the bicarb has increased greater than 26, you're now considered a fully compensated respiratory acidosis. These are your patients you're going to see who have COPD, who live in what we call the 50-50 club. Their pH is like 7.35, their CO2 is like 50, their bicarb's like 33, and then their PO2 is like in the 50s. So, and the same thing goes with alkalosis and also your metabolics. pH is acidotic versus alkalotic, and your CO2 fluctuates to help deal with your lower levels of sodium bicarb. And then you can also have a combined acidosis either way. You don't see those nearly as often because the body's usually swinging the pendulum one way or another to try and compensate for it. So, important things to know about oxygen saturation. So if you're satting 97% with a hemoglobin of 10, it's not going to be as good as satting 97% with a hemoglobin of 15. So the more hemoglobin you have available to transport, the better your oxygenation is going to be. This just means there's more train cars that transport the oxygen to the destination it needs to go. So we have certain things too that will cause the SaO2 to be good, but it's not quite effective of getting the blood to the cell. Now, alkalosis, hypothermia, then the carboxyhemoglobin. Now, like we talked about with the oxyhemoglobin disassociation curve, it shifts that curve to the left. Now, that means it decreases the affinity for oxygen, which means the oxygen's hanging on to it, or the body's hanging on to the oxygen itself. So you have to correct the alkalosis, warm them up, and the body will start offloading the O2 to where it needs to go. Now, carboxyhemoglobin, that just means it's increased due to carbon monoxide poisoning. We've had that before too. Those patients, you want to hurry up and either get them into a hyperbaric chamber, which a lot of them don't really exist anymore. There's some, but they're not generally used as much. But usually you put these patients on a non-rebreather and you try and flush all that carbon monoxide out, because carbon monoxide actually has a higher affinity for hemoglobin than oxygen itself or carbon dioxide. So thank you for being here for my first video, and if anybody has any questions, you can email me at mediocrerrt@gmail.com, or if you have anything else you would like me to talk about, I'm always open for suggestions. So thank you.